Everyone, thank you for the wonderful introduction from Dr. Savoir and also wonderful talk. Thank you. And I want to thank our conference organizers, first of all, for having me here today. It's such a delight and a pleasure to be here. And I also want to start by just acknowledging and honoring the lived experience and expertise that we have in this room. The stories that any of you would share are more powerful than what I can share today, and I just want to recognize that before I get started. As Dr. Savoir mentioned, I'm a clinical and health psychologist, and I work at Toronto Western Hospital in the Comprehensive Integrated Pain Program, and also a little bit in the spontaneous intracranial hypotension program there as well. I don't have any disclosures to declare today. So before we get started, I just want to review some of the common symptoms that you all already know a lot about. So some of the common symptoms that we've heard about in this conference and that you are very closely aware of are things like orthostatic headache, dizziness, nausea, tinnitus, ear pressure, vision changes, and of course disability related to lying flat, difficulties doing activities of daily living, and difficulties working. If we look at chronic pain and mental health more generally, we know that chronic pain can impact mood and general functioning, so it's no surprise that these two things, chronic pain and mental health conditions, would co-occur in high morbidity. So for something like depression, major depressive disorder, we know that the rates are somewhere around 1 to 60%. For some anxiety conditions like generalized anxiety disorder or agoraphobia, it's less, about 1 to 10%. And for other mental health conditions like PTSD or bipolar disorder, it's around 1 to 21 or 23%. If we look at mental health symptoms in individuals with spontaneous intracranial hypotension or CSF leak, there's a lot less known. There's a lot less in the literature. A recent study evaluated patients who were surgical seeking in 2022 to 2023, and measures were collected at baseline and at 3 and 6 months post-surgery. And these study authors looked at somatic symptoms, but also depression, using a questionnaire called the PHQ-8 in this case. Usually it's the PHQ-9, but they eliminated an item looking at suicidal ideation. And we heard from one of the speakers yesterday that that can be an important thing to look at. It can be an experience that's relevant for SIH. They found that preoperatively, about 63% of patients were above a cutoff of 10, which would be indicative of depression symptoms. But after surgery at 3 and 6 months, the rates went down to about 23%. And so we know that, in over half of half of people who are seeking surgery who are living with SIH may be experiencing depression, but these symptoms can improve after surgery, which makes sense if a lot of the symptoms are getting better as well, right? And then in the CSF Leak Association in the UK, they did a cross-sectional web-based survey looking at employment, looking at quality of life, disability, and mental health. And we also heard from Dr. Yasmin Hoydonks yesterday about some of these similar experiences in a Canadian cohort. And these authors found that in about 64 individuals, in terms of the number of people who had confirmed SIH in their larger sample, that there were high impacts in these different areas, which is no surprise to the people in this room, of course. So 60% of people had to amend work duties, about a quarter had lost their jobs or had to discontinue working, and about 67% had financial health impacted. And the numbers that we heard yesterday from Dr. Yasmin Hoydonks were even higher than this. So we know in Canada these numbers can even be higher. Regarding quality of life, we had, again, similarly high rates for things like self-care, pain, depression, anxiety, and difficulties doing regular daily activities. Results from the headache disability questionnaire showed that 95% of people were in the severe impact range. And in this study, when they looked at mental health, they used a questionnaire called the Hospital Anxiety and Depression Scale. And this one had a cutoff of 11, and we had 55% of people in this study reporting significant depression and 38% reporting significant anxiety. So we can see that obviously all of these areas of living are really impacted by living with SIH. However, despite the fact that we can see this, there are no evidence-based forms of psychological therapies for individuals living with SIH or CSF leak or rebound hypertension, these things that can occur after treatment. In addition, recent multidisciplinary clinical consensus guidelines had a multidisciplinary team reviewing the evidence, and they did not have a clinical psychologist on their multidisciplinary team. And they also didn't have any recommendations for mental health supports as part of the usual care pathway for individuals living with this condition. So I think that we can see that there's a bit of a black hole here. So we know that SIH can really impact psychological well-being. We heard about this today in Dr. Savoir's talk as well, some really wonderful coping strategies that are consistent with some things that I'm going to talk about today. And we know that added mental health supports can be really useful. So at Toronto Western Hospital, we do have an established referral pathway. It starts with our wonderful clinical nurse coordinator who's in the audience today, Anna, and also from our pain physician colleagues. And so when a patient is referred to the psychology team, they will start by having an individual consultation, and we will review the background. So both medical background, including the SIH history, CSF, other medical conditions, and of course, and importantly, pain. Consistent with what we saw even in the impacts of quality of living, we look at functioning, relationships, employment, education, and then specific to my profession, we look at mental health background. So what are the things that are impacting you? Is it depression, anxiety? Could it be panic attacks, history of trauma, difficulties using substances, etc.? I provide short-term psychological therapies for individuals in our clinic, and I use acceptance and commitment therapy, and that's what I'll be talking mostly about today. But I also integrate mind-body skills, so that includes mindfulness, and we heard about self-compassion. And like Dr. Savoir, I really recommend Dr. Kristen Neff's website, so it's great to have that plug. And I also use something called clinical hypnotherapy. At times, I also draw from emotion-focused therapy, supporting some of the emotional experiences that can be really present in this condition. So I just mentioned that we don't have any evidence-based forms of psychological therapies for SIH. So why would I pick ACT as a good treatment to use in this situation? Well, ACT is an evidence-based form of therapy for other chronic illnesses and for chronic pain, and it represents a new way to be with a stubborn problem. Dr. Savoir mentioned that although treatments can be very effective, it's not necessarily a cure, and there may be some symptoms that persist, and then maybe after treatment there can be other symptoms that develop as well. And so when we look at ACT, we really want to be understanding that one of the critical premises of this model of therapy is that some of the difficult parts of life that can be filled with grief or disappointment or suffering, these are inevitable in human life. And this premise is really important in understanding this model of therapy. So unlike some models of therapy or some general medical therapies for chronic pain, we're not trying to control or reduce or cure chronic pain or the stuff that goes along with the chronic pain, other physical symptoms or mental health symptoms. The focus really is on adapting effective behaviors that are useful for you, that move you towards the big life, the things that you hold important. And Dr. Savoir had some really wonderful terminology around this, some really heart-based language around the things that make your life meaningful. So we really want to work on how different difficult experiences, including thoughts, feelings, sensations, how those things are experienced, but not necessarily changing them directly. So what is ACT? ACT is a process-based third-wave cognitive behavioral therapy that really fosters openness, awareness, and engagement. It's grounded in something called relational frame theory, which is a theory of language and cognition. And at its core, it's a functional and contextual framework. And that will become clear when I give some examples today. It uses a lot of different tools, including cognitive tools, experiential tools, mindfulness, values-based stuff, and experiential. It's transdiagnostic, which means it can be useful for a variety of different types of symptoms and conditions, and also just life challenges. There are a lot of systematic reviews at this point evaluating ACT for chronic pain, not for SIH. And the most recent one came out of Spain last year, and the authors did an overview of these review articles. So we really look at these systematic reviews with meta-analyses. That's really how we want to get a good sense of what's in the literature. And we're at a point now with this form of therapy where we got an overview of those overviews. They included 9 overviews of these systematic reviews with meta-analyses for individuals who were diagnosed with a chronic pain condition who received ACT either as a standalone intervention or conjointly with another intervention, and they grouped them into kind of different categories when they looked at outcomes, either positive, negative, or inconsistent. It's important to keep in mind that this is a pretty stringent way of looking at the data. What I mean by that is it's pretty strict, and so it's more conservative. And so when we look at things like pain intensity, pain-related functioning, and quality of living, they found inconsistent results across the studies. But when we look at some of those psychological factors, like psychological flexibility, which I'll be talking about in a minute, anxiety and depression, which we've already touched on, and things like pain catastrophizing or chronic pain acceptance, all of these things were positive after. They concluded that ACT could improve some of these areas, but of course more research is needed in terms of high-quality trials and reviews. So now that we've covered some of the basics, let's look at ACT and what it is. It's essentially, in its core, a model of psychological flexibility, and it has 6 theoretical processes. And so it's not explicitly a goal to be teaching these or to have you necessarily know their terminology or what they are. When we're working with these processes in therapy, we just want to engage in behaviors that capture these. And so if we take a look at these, there's values. This is who and what matters, and we had some really great examples of that already today. We have committed action, and these are the effective physical and sometimes mental steps that we take towards those things that matter. Present moment awareness captures that mindful attitude of being aware of thoughts and feelings and everything in the here and now. Acceptance is being willing to experience the present moment as it is without needing to change. And this is a really delicate topic in all chronic illness, including SIH. And then we have, oops, sorry about that. Let's get back to the slide, pardon me. And then we just have a couple others. We have self as context, or one other, self as context, which is just loosening the grip of your self story or concrete aspects of identity. And this just means coming back repeatedly to the present moment and sensory experience. So I've mentioned that at its core, it's psychological flexibility, and this is the ability to engage in these 6 processes kind of at the same time. So you can be open, aware, engaged, both cognitive, sensory experience, and you can choose behaviors that move you towards what matters based on what your situation or day affords. So now that we've covered the framework for ACT, let's look at how this might be relevant for SIH. What are some key psychological themes that might be present? And some of these might ding bells for you, and others maybe not so much. Some that I want to present here today are hypervigilance of physical symptoms, and this could be fluctuations in pressure, in pain, or tinnitus, or other symptoms in the body. Distrust of the body, and we've heard about that already today. Mentally tracking symptoms in response to different behaviors, so that constant kind of seeing what am I doing and what does it do to internally. Fear of the leak returning or a future disability. General feelings of vulnerability and loss of control. Memories related to difficult experience and dependence on others. So stemming from these concerns and themes, what are some goals that I might work on with individuals living with this? So we would really want to focus on psychological adjustment to SIH and possible symptoms, managing uncertainty regarding that recurrence, and we had a question around that today, is like, how do we tolerate that uncertainty with the future? Addressing anxiety related to specific physical symptoms and what those symptoms could mean, emotion regulation or emotion processing of difficult experiences, and also mind-body skills. So that's getting back to mindfulness, compassion, and hypnosis. So one of the exercises that we use is the ACT matrix. And this is an exercise that I really like as a starting point because it gives that big picture perspective, it sets a course for the future, it gets a sense of where things are at present, and it captures all the 6 processes that I described a moment ago. So it's pretty simple when it boils down to what it actually entails. And you'll see that there are 2 lines on the page. So we have this horizontal line and we have this vertical line. So everything that is above that horizontal line is represented by a video camera. And that captures mostly the things I might see you do on camera, usually physical behaviors that I could see you do with your body, but sometimes also it's things that you do with your mind. Everything underneath that horizontal line is represented by the heart at the bottom of the page, and this represents the things that only you can experience. Your thoughts, the feelings that you have, the physical symptoms that you might be experiencing, sleeplessness, nightmares, whatever it is, all of that stuff. You'll see that that line also kind of goes in 2 directions, and you'll see on one side we have the word away, and the other side we have the word toward. And so what this captures is that we can do behaviors. We can engage in behaviors that either move towards things that matter or sometimes coping strategies, moving away from the things that are hard. And Dr. Savor mentioned today lying down to do something that matters, and this is a perfect example of that. So the easiest way of understanding towards moves and away moves in the ACT framework is imagine you have a child running on a schoolyard. They could be running toward a friend. This is towards something they care about, towards something meaningful, or away from a bully, away from something threatening, something that's scary or difficult. The behavior is the same, it's running, but the context is very different, and the function of the behavior is also very different. And that's really important in ACT. We want to look at behaviors and what they're doing for you and whether they're working. So then if we look at the 4 quadrants, each one represents a different part of your experience or your behavior. So we have the values at the very bottom, which are represented by the compass. Just like a compass has a North Star that always sets the direction, the values that you each hold as important are those guiding directions for your life. In the bottom left, we have this alarm, which is the alarm of any physical sensations that might be activated. It could also be really strong pain, different alarms of the internal body. Then we have this turtle, which captures, behavioral withdrawal when you're having really bad symptoms. Maybe you've tried that feeling, wanting to shut the light and crawl into bed like a turtle going into their shell. We call these the away moves. So that's that child running away from a bully. And then we have the steps taken in the top right quadrant. These are the steps that you take towards growing that life that is going to be the big life, the rich life that you want. And so we can really look at these different quadrants to capture this big picture perspective, and that's that mountain in the middle. Because as we talk about this today, it would be different for each one of you, what goes into each one of these quadrants, and only you standing on that mountain in the middle can see the full landscape, to see what matters, what might be showing up in your body, what are the things that you might need to do to manage those symptoms, and what are the things that you want to do to move towards that big life. So if we look at some examples of what this might include, for values, we have things like family, children, friends, partner. We have activities that could be meaningful. We have health, pets. It could be spirituality. We had a really nice, broad definition of religion earlier this morning. All these things that could be deeply important to you. And then if we have the things that could potentially hurt inside. This could be pain, it could be a headache, it could be internal sensations in your ears, or difficulties when you move, or light sensitivity, difficulties trusting the body. It could be fear related to symptoms or recurrence, or just general anxiety. Or it could be questions around diagnosis, or frustrations about lack of clarity about certain symptoms, anything like that. I'm not trying to make things disappear. I'm trying to make more things appear. Here we go. All right, so the turtle moves, those away moves could be things like tracking symptoms. It could be tearfulness. It could be postural changes, so trying to get some symptom relief by moving around, lying down, standing up. It could be social isolation. We had a theme today already of groups or being online researching, all of that. And then in terms of towards moves, it could be spending time with friends and family in a way that's manageable for your symptom level that day, engaging in physical activity in a safe way, like walking for over 40 minutes for a normal 10-minute walk, taking breaks on a bench as you need. It could be meditation, taking a trip, engaging in safe physical activity, and spending time just generally with people who are important to you. And just like that child running on a schoolyard, I want to just highlight here that you could have a behavior that is both. So it's not like the away moves are kind of bad and the towards moves are good. It's not like that. We need both, just like, we have a balance in life. We need both sides of this, and we really want to be using those away moves to help power the towards moves. So if you have something like maybe tracking symptoms, sometimes that might be helpful. It gives you information about what's a safe activity or what your limits are, but other times it might be a bit anxiety provoking if there's a lot of time spent on that, and we'll be talking about that in a couple of slides. This can be further deepened. We can kind of do a few more things with this exercise. Let's say you've been spending a lot of time lying down, then we can work on creating a paced behavioral activation plan based on different intensity levels of symptoms. So let's say you had a goal, just to continue with Dr. Sabor's example of walking. You might want to say, okay, my goal for physical activity is walking 7 minutes today if my symptom intensity is 4 out of 10, but if it's a 7 out of 10, my goal is just to even get out on the porch and be outside and sit down. So it's like noticing, okay, what is the symptom level? What is the value? What's important? And how can I still act on that value despite what is happening? Because when you act on a value that's important, then you get a connection to yourself as well and something that's meaningful, and that can be very comforting. You can also take a look at what we call the stuck cycle, which is when sometimes the things that we do to get away from the stuff that's hard can be helpful for a short while, but if we engage with it for a long while, it can actually sometimes bring us back down here. So let's say you are feeling really socially isolated, and that could be a difficult experience, but then because your symptoms are so high, you're also spending a lot of time lying alone, and then that can reinforce that feeling of social isolation. So we just want to be aware of the ways in which that can happen and sometimes interrupt that. So let's take a look at one of these processes I outlined a second ago. So cognitive diffusion. This is a mental process of disconnecting from, distancing from, or observing thoughts for what they are, which are usually mental events made up of language in the mind, but they can also be things like images or memories. And so we really want to be looking at the types of thoughts that could be frequently happening. So things like, how will I know if I'm leaking, or will this be coming back, or I'm preaching to the choir. You know the thoughts that you have related to your experience, and you'll know when they're kind of coming at a higher frequency or intensity, and maybe when that is difficult. So we use different cognitive diffusion strategies, including things like the clipboard exercise, or thoughts that hook, or simply mindfulness of thoughts. And if I take a look at one of these exercises, thoughts that hook, this is something that we can do to kind of get perspective on some of those trickier thoughts. And so really we want to become aware of habitual thoughts or automatic behaviors that just aren't working anymore. Maybe they started out to be effective, and then over time maybe not as much. And so we really want to be creating some working distance between your inner witness and what those thoughts are. So let's take a look at an example. So let's say you're having a lot of thoughts about different symptoms, or monitoring symptoms, or maybe thoughts about like a fear of a future recurrence. Then we want to look at, is engaging in that line of thinking helpful? What does it do for you? What is the next experience after you engage in that? So when you frankly look at that and you can kind of see, is it giving me something useful, or perhaps is it making me feel really anxious, or making me feel more distressed or out of control, then if it's the second situation, then you might want to be engaging in a cognitive diffusion strategy such as mindfulness of thoughts, or potentially just rerouting, doing something that's meaningful for you, giving yourself a sense of accomplishment that way, engaging in self-care, or potentially sometimes even distraction. So if we pause for a second and talk about this thing that's kind of come up a few times, which is this delicate balance of monitoring. So why might you engage in monitoring, right? Like monitoring symptoms? Well, because you need to, because some of these symptoms can signal that there's something very serious happening. And so there is an element of necessity there. But then also, if you monitor too much, it can create these other internal experiences of anxiety or fear, or it can just, in some ways, take your focus and take it away from the things that really matter to you, that are important to you. And then it's sort of like the magnifying glass is just on monitoring. And this is where we want to kind of notice when that balance shifts. So what can go wrong? What I just mentioned is too much focus can happen on these on monitoring and these symptoms, and that can result in secondary things like anxiety and fear. So to kind of address this, it's like, okay, can I notice what is happening without engaging in like kind of an over monitoring behavior, and also maybe review things that I've been told by my medical providers, providing I trust that information, remind myself that I'm safe. And just for each person, it's examining the function of that behavior. So in ACT, when I mentioned it's a contextual and functional model, this is what we're doing is this behavior working? Is it effective for you? And if not, trying something different. And one of those things that you can try is mindfulness. And mindfulness is a very simple practice of paying attention moment by moment to the present, without judgment, with an attitude of openness and awareness. And it involves adopting a dispassionate stance to all different types of experiences, thoughts, emotions, behaviors, and also the outer sensory world. And it has both formal meditation practices, that's probably what you think of when you think of meditation, eyes closed, maybe listening to a recording, directing your attention to the breath or thoughts. But it also involves really simple ways of being and living in your daily life that are informal. Brushing your teeth, not being on automatic pilot, so being present for your sensory, emotional experience as you do these activities. For both kind of approaches, informal and formal, it's a practice of training your attention to come back to the present again and again. And what do we know about mindfulness for chronic pain? Well, a meta-analysis evaluated of almost 40 randomized controlled trials looking at a variety of different types of mindfulness programs. So mindfulness is at a state of the literature where we have what's called a protocolized program, like mindfulness-based stress reduction, mindfulness-based cognitive therapy. But this study also included non-protocolized mindfulness programs, so just kind of general mindfulness programs that ranged in length from 3 to 12 weeks, but on average about 8 weeks. And in this study, they compared mindfulness to a variety of different types of controls. And we do that in research to make sure that the intervention is actually doing something above and beyond these other things, like CBT or relaxation or treatment as usual or stretching. I think they used a nutrition one in one of them. And they found that mindfulness can improve pain, depression, and quality of life. However, when we look specifically at headache as a subpopulation for chronic pain, the literature is less clear and the findings are more inconsistent for mindfulness, specifically for migraine and headache. Some patients also experience anxiety leading up to medical procedures, such as an epidural blood patch. And I can support individuals who are experiencing that type of anxiety before their blood patch in managing the anxiety related to the procedure itself, or sometimes it can bring up anxiety about whether or not it will work and what that means for the future, and also perceived lack of control during the procedure itself. So when this happens, I can help with providing a toolkit in 3 phases, and this is something that if you are going forward with another procedure, you can kind of think about this for the future. So kind of bolstering your psychological wellness before the procedure, and so that's whatever your regular toolkit is or some of the suggestions that Dr. Savoir mentioned, and this can include things like mindfulness, cognitive strategies, self-care, or anything that you find gives you that lift. Perhaps nature is something that's really meaningful for you. So going for walks in nature leading up to something like this type of medical procedure can just help give you that sense of resilience and strength. I also help patients for a coping strategy for during the procedure. So if someone experiences panic attacks during their procedure, then providing information about panic attacks prior to the procedure and then panic de-escalation strategies can be helpful. Other things like 5 senses mindfulness, affirmations, grounding strategies, all of these kinds of things can be helpful, and they're really unique for each person. And then after the infusion, there's some adaptation. We know that there can be heightened other symptoms after a procedure, like an epidural blood patch, some of that rebound, hypertension, and other symptoms. And so having some psychological strategies for that period, like even reframing rest as a positive thing or sweetening the downtime, like those self-soothing techniques that were brought up earlier. These are all things that can be helpful in adapting to that kind of transient period post-epidural blood patch in generating some calm and sweetness. And after a blood patch, many symptoms can improve. And we've heard about that from a lot of our speakers yesterday, from our patient stories yesterday and also today. But also sometimes it can be hard to move forward. Some of the experiences are so significant, so profound, and can be so disabling, and the pain is so severe that it's almost like, how do you kind of suddenly move forward when all of this stuff has happened and you need to integrate it and kind of have some resolution before moving forward? And in addition to the degree of the disability of having to lie flat all the time and having, activities of daily living kind of stripped away, there can be other things as well, like just the loss of control, feelings of helplessness and vulnerability, or changes in the way that, you're able to show up in relationships for people you care about, changes in how those relationship dynamics are happening, and also confusion related to like how long it took to get a diagnosis, years for many people, and frustrations associated with that as well. So when this becomes an important part of therapy, then I will draw from a different model of therapy called emotion-focused therapy to really just help support processing these experiences, exploring them, and trying to reach some resolution. Lastly, I offer patients clinical hypnotherapy as an additional mind-body coping strategy, and really the goal here is around gentle symptom relief and some relaxation. So what is hypnosis? It's not like stage hypnosis, which you might have heard of. There's no like clucking like a chicken or standing on your head. There's nothing like that. It's just really a way of deeply relaxing and taking your mind somewhere else. So it's a way of connecting internally, and it often creates subjective experiences that are characteristic of like openness, immersion, immersion, some dissociation, and as I said, deep relaxation. So there's a few different components that are standard in a hypnotic, it's called induction, but this is also unique to each person, and I work with each person to find a set of these components that work really well for you. I always say that hypnosis is like a lock and a key, right? And so each person has a slightly different key that's going to fit the lock a little different, so we find out what that like specific wiggle room is. So these kind of components include things like deep breathing, inner absorption in a really lovely special place, suggestions for altered experiences internally, progressive relaxation, these kinds of things. The research evidence for hypnosis for chronic pain is somewhat less than for some other psychological therapies, but there's definitely enough evidence to warrant its use. And so this is something that we do use, and a recent meta-analysis that I looked at actually found that in order for it to be really effective, it's really recommended to have at least 8 sessions of clinical hypnotherapy. As well, some experts in the field really recommend looking at something called responder analysis, because everyone is a little different in terms of how hypnotizable they are, or how well it works right away, although I also say that this is a skill that can be learned by anyone. And so if we're going to kind of take that expert opinion in mind, we want to really be looking at these subpopulations of people who actually do respond. Importantly, at Toronto General Hospital, we have a sister service of pain psychologists who work in the Ehlers-Danlos Clinic, and they use hypnosis for things like nausea, and this can be relevant, especially post-epidural blood patch. So in summary, the literature on mental health experiences in SIH and CSF leak are limited. We do have some information about the rates of anxiety and depression, or just the percentages of individuals experiencing these symptoms, but it's really limited to that. So we have 55% of patients who may experience depression, 38% who may experience anxiety, and of course there's very significant impacts on different areas of quality of living, but we don't have the research right now. We just don't know what's an evidence-based form of therapy for individuals living with these impacts. At the SIH clinic at Toronto Western Hospital, I provide acceptance and commitment therapy, as it's an evidence-based form of therapy for chronic pain more generally and other chronic illnesses. And where possible, we draw in these mind-body approaches, self-compassion, mindfulness, hypnosis, and emotion-focused therapies. So that's it for my presentation today. I just want to also really recognize the patients that I've worked with that have really taught me about the lived experience of living with this condition. That's been really a powerful experience for me, and I'm very grateful. I also want to thank all of you for your attention today, for prioritizing coming to this conference, and for being here for my presentation. Thank you so much.